talk about the various tips and tricks to do a safe cholecystectomy. And I'm also going to talk about the pitfalls which actually lead to some serious complications and then how to safely come out of those sticky situations. And we are all well aware that as of today, laparoscopic cholecystectomy is the gold standard for the treatment of gallstone disease. The first laparoscopic cholecystectomy was performed way back in 1985 by Professor Eric Muhe. And it was considered quite a revolutionary idea at that time. And it initially actually faced a lot of criticism also from the contemporaries. However, lap chole came into vogue and earned its respect after a lot of work was done by Professor Philippe Moret from France, who actually popularized this surgery using video guidance. Broadly speaking, laparoscopic cholecystectomy is basically a four-step surgery. The first step being that the creation of the pneumoperitoneum and putting your ports for the access. The second step basically involves a dissection in the area of the callus triangle and identification of the important structures, which are basically a cystic duct and the cystic artery. Once you have identified these structures, you have confirmed these structures, then you're going to go ahead and clip and divide these two ductal structures. This is followed by the removal of the gallbladder from the liver bed and retrieval. So I'm not going to talk about the steps. I'm assuming that all the surgeons here are aware how to do a laparoscopic cholecystectomy. My focus of the talk is basically on how to do a safe cholecystectomy. So I'm going to start by discussing some important tips for every surgeon to do a safe lap chole. Surgeon should be with the relevant surgical anatomy. He should be able to understand what are the anatomically safe zones where the surgeon can go ahead and operate safely. And obviously, then every surgeon should be familiar about the critical view of the safety. This is a very important concept to minimize complications. I'm going to talk about the normal anatomy to begin with. We all understand that the gallbladder is attached to the liver bed. It lies between segment 4 and 5 of the liver. It has a duct which is usually 2 to 4 centimeters and about 2 to 3 millimeters in diameter. Normally, in most of the cases, it tends to join or connect with the common hepatic duct from the right side. Similarly, we also have a single cystic artery, which most of the time originates from the right hepatic artery, crosses the area which we now identify as a hepatocystic triangle, and again connects, or rather divides into a deep which enter into the wall of the gallbladder. But this is just a standard guideline anatomy. Every surgeon knows that there are so many anatomical areas of the cystic duct. Now, the cystic duct may actually be very long and may have a low union with the common hepatic duct. Or it may turn out to be a very short or even an absent cystic duct, and you may have a sessile gallbladder. In some other case, you may find that the cystic duct is doing the anti-spiral common and connecting to it from the left side. Now, this could be either an anterior spiral anatomy or even a posterior spiral anatomy. Not only that, many a times we come across some accessory cystic ducts. The duct of Luschka is a very classical example of that. Now, in addition to the standard cystic duct, these are in ductal connections which may be running between the gallbladder and the liver bed or some part of the extrahepatic biliary tree. Similarly, the cystic artery itself can have lots of variations. It is believed to originate from the right hepatic artery in most of the cases. However, in 25% of the cases, the superficial and the deep branch of the cystic artery, they have separate origins. Now, in these cases, as a rule, the deeper or the posterior branch of the cystic artery usually tends to arise from the right hepatic artery, whereas the superficial cystic artery, as we may call it, can arise from either the right, middle, or the left hepatic artery, or even from the gastric or a reproducible artery. Not only that, besides the presence of a single cystic artery in the callus triangle, there may be accessory arteries coming from different origins and lying in the vicinity of the gallbladder. In fact, you may come across a scenario where you do not find the cystic artery where you expect to find it, which is in the callus or the hepatocystic triangle. In a even further variation, you may have a single or a double artery, but both of them are lying outside the area of the callus triangle. So what is happening here is that there is no fixed anatomy in laparoscopic cholecystectomy. We just have guidelines, and then we have a long list of variations which can be present in a particular case. Going in, the surgeon does not know. Then what should be the approach of a surgeon while doing a laparoscopic cholecystectomy? Well, it is important to remember not to have a preconceived notion about where the structures are. In fact, the best and the safe approach is to carry out the adequate dissection in that area and then decide what the structure is which you are looking at. Do not have a preconceived notion that this is my cystic duct and this is my artery. You need to fully dissect out that area so that you can correctly identify the structures. So this is where the concept of this surgical anatomy becomes very relevant, because most of the bile duct injuries occur not because of some technical error, but because of the misidentification or misinterpretation. So laparoscopic surgeons should know these three anatomical trains: the callus triangle and the hepatocystic triangle, the ruveus sulcus and the segment 4 line, and obviously critical view of the safety. I'm going to talk a little bit about all of these important anatomical terrains. Well, callus triangle is a concept which has been known to us since the very beginning of our cholecystectomies. This is an area which is bounded on the left by the cystic duct, on the right or the lateral side by the common hepatic duct, and the superior border is formed by the cystic artery and not by the inferior border of the liver, as many people commonly believe. However, the concepts have slightly evolved from here, and modern surgeons usually go and try to identify the hepatocystic triangle rather than the standard callus. So this hepatocystic triangle again basically is a triangular area, but the boundaries are that now it has a cystic duct on the lateral side, the common hepatic duct on the medial side, whereas the third side of this triangle is not formed by the cystic artery, but by the inferior surface of the liver. And this is a more important anatomical area for all laparoscopic surgeons, because this hepatocystic triangle is believed to contain the cystic artery. The sentinel lymph node or the Mascagni lymph nodes is believed to be closely associated with the cystic artery within this area. That there's going to be a little bit of lymphatics, some connective tissue, and some variable vessels and ducts can also be present. So this is going to be a main area of dissection. So you can see here in this picture, the yellow area, the triangle represents the callus, whereas the bigger bluish triangle is the hepatocystic triangle. As a matter of fact, the callus is actually a small part of the hepatocystic triangle, if you can see from this image. Next is the important landmark is the ruveus sulcus. Now, this is basically a fissure which is present between the right lobe and the caudate lobe of the liver and is considered to be one of the most important landmarks in doing a laparoscopic cholecystectomy. You will see this fissure in almost 80 to 90% of the cases. And in the other patients, the remaining 10 to 20%, if the fissure is not present, you tend to see a small scar there instead of a fissure. The importance of the ruveus sulcus is that the common bile duct lies anterior and inferior to this ruveus sulcus. So the rule every surgeon needs to remember is do not dissect below the level of the ruveus sulcus. As long as you are above the ruveus sulcus, you are in a safe zone. You would be sorry if you start dissecting below the level of the ruveus sulcus. So it basically tells you the safe plane of dissection. Then there is an additional landmark which we now consider and call it the segment 4 line, or you can also call it the R4U line, which is basically an imaginary line connecting the ruveus sulcus, the base of the segment 4, and going all the way up to the umbilical fissure of the liver. Now, this represents a safe plane of dissections. Again, the concept is surgeons should remain above the level of this R4 line, and that is a safe area of dissection. Then comes the most important concept, which is the critical view of safety, which was suggested by Strasberg way back in 1995. So we must understand the CVS is a method of target identification to identify the structures, and it is achieved by doing appropriate dissection. But the CVS does not tell you how to dissect. It is actually telling you what should be the final picture after you have done the dissection in that area. So one must understand that it is used to identify the cystic duct and the cystic arteries. So there are basically three components of achieving a critical view of safety. The first is that you must clear the entire hepatocystic triangle, the anatomy which I just defined in the previous slides. Clear the entire hepatocystic triangle of all the fibrofatty tissue. You do not need to expose the CBD for doing this. Just stick towards the gallbladder side. The second prerequisite is that the cystic plate is exposed by separating at least the lower one-third of the gallbladder. One-third of the gallbladder attachment should be removed from the cystic plate. And lastly, you should be seeing two and only two structures, which both of them are entering into the gallbladder. When you see all these three things after your dissection, this confirms that you have achieved the critical view of safety. You can see here in this image, this is the gallbladder which has been separated in its lower one-third from the cystic plate. You see two ductal structures which are going into, and we have flipped the gallbladder so that we can see both from the anterior as well as the posterior, or you may just call it the medial as well as the lateral view. There is nothing else present in this area, only two ductal structures which are going into the gallbladder. So if you put all these landmarks and concepts together, then you can start recognizing a safe area, a safe anatomical area where you are supposed to do the dissection. So to do a safe laparoscopic cholecystectomy, the surgeon should remain above the Ruvius sulcus and the R4 line, should stay close to the gallbladder wall during dissection, avoid doing any deep dissection on the medial aspect. So stay away from the common hepatic duct or the common bile duct. And finally, you should be able to demonstrate the achievement of a critical view of safety before you clip, ligate, or divide any structure.